So channelopathies are nothing but basically the genetic defects in the gene coding, and they are the ones which will be leading to ECG abnormalities. Okay, and they are the ones which lead to life-threatening ventricular arrhythmias. So on the ECG, if you'll be trying to see, you may see either short QT, long QT, or even Brugada syndromes as well. In the long QT, what happens? Okay, the one of the most common forms which you normally see is Romano-Ward syndrome. In Romano-Ward syndrome, what will be happening is there is prolonged depolarization of the ventricle. There's already standard definition as well, what is called as for the QT corrected. QT corrected is root of RR interval divided by QT interval. So that's how you get the corrected QT interval. Corrected QT is important because you should be able to define a QT interval which is independent of the cycle length. So because if someone is having a bradycardia, that is the time when you can have prolonged QT, but you don't want all these kind of things. So for that, what you do is you try to correct to get is the corrected QT interval. So this is the formula which I was telling you. So this is what is called as the Bezet's formula for getting this, right? So you should always be careful how are you taking the tangent from this T wave, and using that is the one you will be able to get it in fact. So what happens is there are different types will be having different ways of getting aggravated as well. In the sense, one will be the one which tends to happen during exertion. So one being the first one, a lot of exertion, swimming, exertion, emotion, like this. However, the long T no, the long QT2 is the one which needs auditory triggers. Auditory triggers, for example, if someone drinks a phone and gets a arrhythmia, like that. Similarly, otherwise, postpartum period. Postpartum period. Okay, so postpartum period is a mother who, for example, has already delivered a baby and then gets a problem. Then comes the long QT3. Long QT3 is the one which is associated with SCN5A mutation. Okay, don't forget that. So that is the one when the arrhythmias is going to happen during the sleep. In the sense, a lot of times you would have heard, no, someone died during the sleep, and if it is due to QT prolonged, most commonly it would be long QT3 in fact. So SCN5A mutation. Don't forget about that. Okay. So as I was telling you, so I had already said it about the type 1, type 2, type 3. So the type 1, as I had, so what you notice is there's broad-based T wave. Broad T wave, okay? However, the type 2 is the one with notched or biphasic T wave. Okay, T wave is more of a biphasic. Okay. However, for the type 3, there is long isoelectric. So, for example, the T wave will be a normal, like a narrow, small one. There will be a isoelectric interval. Okay, isoelectric interval which is present normally after the T wave. So as I had said it about type 1, 2, 3, don't forget. So the type 1 is during exertion, during swimming, exertion or emotion. And the type 2 was for either in peripartum period, otherwise due to auditory stimulus. And the long QT3 was the SCN5A mutation, which was happening during rest or even sleep. So as you may notice over here, so QT is pretty prolonged, right? Even the other thing what tends to happen is there's also like 1, 2, 3, 4. Okay, sinus rhythm. I wouldn't say it as bradycardia, but of course QTC is also prolonged. However, now what is happening in this ECG? So in this ECG, if you look carefully, the T wave seems to be biphasic and the notched as well. So this is the one with type 2. Then comes this ECG. So in this ECG, what do you notice is, yes, T wave seems to be pretty narrowed And after that, there is a isoelectric interval and of course a PU. So this is the long QT interval with type 3, which is the one which is associated with SCN5A mutation, in fact. So there is a very important term, if you look carefully in the ECG, what is called as the macroscopic T-wave alternance. So why the alternance? Alternance is the one which refers to the alteration of the T wave in polarity or even amplitude. So what will happen is in the long lead 2, a T wave with positive polarity will be followed with next negative T wave polarity. Okay, and it keeps on alternating. So what do you as if you will, this is the rhythm strip. Okay, so in the rhythm strip, what is happening? So you see initially is the positive and the negative T wave, and which keeps on alternating, isn't it? That's what we are noticing over here. So this is a young kid which was having the same problem and who has had multiple episodes of cardiac arrest. So if anyone is having a long QT, are they all going to die? No. So what are the risk factors for that? So the risk factors you should be trying to see further if someone has had a history of aborted cardiac arrest, otherwise if there is a family history, syncope, T-wave alternance, otherwise even prolonged QTC, or if there are events in the first year of the life as well. So torsades, we are already aware of what is called as the twisting around the line. So there's actually a polymorphic VT which you tend to see, especially in the setting of a QT prolongation. And there is intervals like the irregular rhythms, like the long, short RR intervals, which you commonly see. So this is how they look like, especially on the ECG. Okay, so this is the trigger point over here. What tends to happen is, so already if you may notice over here, there's slightly prolonged QT. And then over here, it starts to take shape in the form of a twisting which is present. And this is the characteristic, what is called as torsades depointed. So there are, so VPBs were coming, yes, this one as well, and then came like two VPBs and boom, patient deteriorates. So there are several diagnostic criteria as well, using which one can identify. You can give some scoring in the form of, for example, how prolonged is the QT. So if it is more than 480 milliseconds, you tend to give 3, 460 to 479, 2, 450 to 59 is like 1. Similarly, for example, if you have already done the exercise stress test for the person and you see a prolonged QT, okay, 4 minutes, like after the exercise, again, you can give 1 score. And if someone has had or recorded torsades, you will give like almost 2 points. T-wave alternance, you can give 1 point. And if there is notched T-wave in 3 leads, again 1. Similarly, if there is low heart rate for age, you will be giving as 0.5. Similarly, if someone is having a clinical history of syncope, with stress you give 2, without stress will be 1. Similarly, if someone is having a positive family history with the prolonged QT, that is the time you'll be giving score of 1. Okay. So now a lot of times what will be happening is you will be coming across those ECGs. What is happening is in which you notice is this prolonged J wave, especially if there is someone is having a wider QRS. Otherwise, there is a accessory pathway in the form of a W syndrome, or there is an interventricular conduction defect. In those cases, of course, the measurement of the JTC is the much more accurate. Much more accurate. Why am I telling is, okay, let me try to show you what is exactly the difference. So this is the J point, which refers to the junction point. So this is the QRS, and this is the like the QT interval, which is coming over here. So starting from the J to the end of the T wave is the one which refers to the JT interval. So as I already said it, so what happens is, yeah, most of commonly 320 to 400 milliseconds will be there. As I said it, this is not, you don't do it much often. However, only if any of the patient is having, for example, on the ECG, bundle branch block pattern is there, then sudden positive changes where that's why bundle branch block pattern or otherwise accessory pathway is there. Another important phenomenon, what is called as the prolonged QT dispersion. So in the prolonged QT dispersion, there's a maximum and minimum QT interval. And what happens is, if it is more than 65, there is a high risk for ventricular arrhythmias. And it is definitely a risk marker for sudden cardiac death. However, 40 to 50 milliseconds, it is pretty normal. So no need to be worried about that. But if it is more than 65, yes, you have to be worried about that. Similarly, if there is an increased QT dispersion, there will be a inhomogeneity of the ventricular action potential. And definitely it is a marker for the sudden cardiac death. So most of us are definitely aware that, okay, long QT interval is a bad marker. But similarly, if the QT is also very small as well, then this is also not a good marker. In the sense, you will be noticing this is short QT interval is already a autosomal dominant, and three main genetic variants are there. And what happens is, uh, in fact, they all tend to involve the potassium channel genes. And in fact, the short QT1 is the most common interval, okay? So now you can understand it very well. So similarly, in the short QT interval as well, uh, how much is the definition? So can anyone recall over here? So the interval is, if it is less than 330 milliseconds, it is going to be short QT interval, okay? So what will happen is, however, if one is in the range of 330 to 360, so you will need further additional criterias. Additional criterias in the sense like pathogenic mutation, there's a family history of sudden cardiac death or even a short QT syndrome as well. So you should be able to, uh, identify those people. And this is how the short QT ECG will be looking like. So the T wave is characteristically narrow and also symmetrical. And they are the ones who will be having the history of atrial fibrillation and even VT or VF as well. So this is another 16-year-old boy which was presenting with history of syncope. So what do we notice over here is, this is a 12-lead ECG of a patient in sinus rhythm, and when we notice the QT interval, corrected QT interval, it is 280 milliseconds. So already cardiac arrest and syncope has been uh, some of those most common presenting features, especially for the patients of ventricular arrhythmias. And we also need to be aware that syncope is the leading cause for these, is the one which tends to normally happen for the ventricular arrhythmias. And yes, they may also have atrial arrhythmias like the atrial fibrillation and flutter. So what tends to happen is, the diagnostic criteria for the short QT interval is, as we can see it over here. Again, you will be giving the scoring. Scoring will be, for example, on the basis of total score. If it is more than 4, there is a high risk for short QT syndrome. Similarly, 3 for intermediate risk, and less than 2 for low risk. So the another really hyped mechanism in arrhythmias, especially for the sudden cardiac death, is what is called as the Brugada syndrome. So in the Brugada syndrome, what tends to happen? So in the Brugada syndrome, you will be noticing is, as I was already telling, so it's a mutation of actually SCN5A. SCN5A gene is the one which is also responsible for the long QT3, in fact. And most of these people who die are young men who tend to die from the ventricular fibrillation. And in fact, you do notice there's downsloping ST elevation, especially in the right precordial leads, okay, on the ECG. So the ECG pattern can be present at the baseline or even intermittently as well, you may be noticing. So there are three types of Brugadas. So in the sense of, so if you'll try to look carefully, the ST elevation point, especially in the lead V1, V2, V3, you may start appreciating the difference. Okay, so what is happening is in the type 1, you see what is called as the coved type ST segment elevation. And of course, they are there in the right-sided precordial leads, right? And then in the type 2 and 3, rather than a coving, it is more of a saddleback. Saddleback is there. So this was a young patient. When the ECG was being done, and then it was noticed the type of arrhythmia which that patient had. Although, if we look carefully, there's coving of the ST segment which is present, which is the one which is classical for Brugada syndrome. And of course, in the sinus rhythm, we see it a characteristic ECG. So, all the other markers, especially for the Brugada syndrome patients, if there is a prolonged QRS duration as well, so they will be more predisposed for the life-threatening ventricular arrhythmias. So what tends to happen is if the QRS duration mean is 129 plus minus 24 milliseconds, so they tend to be more symptomatic rather than the ones which is like 16 milliseconds in fact. So again, this is again another patient. So one of the other important and nice tricks which you can apply in these kind of patients is try to do a high lead ECG. High lead ECG is in the sense, so you can try to keep the ECG leads in the third and the second intercostal space, okay? So you'll be able to notice it a little bit early, okay? So other than the placement of the higher lead ECG, you can also try to do is give some drugs to those patients. What are the drugs do you give to them is ajmaline. Ajmaline, if you give like 1 mg per kg infusion over 10 minutes, you will be able to notice the unmasking of the Brugada syndrome. Similarly, for the flecainide as well, you tend to notice these kind of changes. But the flecainide, you have to give the IV intravenous dosages will be in the form of 2 milligram per kg IV infusion. Or with the procainamide. The procainamide as well, you tend to give as 10 mg per kg IV infusion over 10 minutes. So, what was happening for this ECG, if you look carefully, is once the IV flecainide infusion was started, later on, with passage of time, Brugada syndrome started becoming more and more evident, right? So similarly, so for example, this is the resting ECG, and this is during the ajmaline testing. So that's what you notice. So a lot of times, a common question comes is, when would you like to perform the provocative test for such patients? So, for example, if someone is really symptomatic, otherwise there is a family history,